Welcome back to MedMythbusters HIV. I'm Rachel Deer with DKB Med. In this second episode, we talk about aging with HIV, comorbidities in people with HIV, and women with HIV. Now I'd like to reintroduce our amazing faculty, 𝐜𝐵𝐲𝐭 Sullivan, a certified physician assistant based in Los Angeles, California. Our learning objective is discuss the prevalence of HIV at different ages. Now, here's 𝐜𝐵𝐲𝐭.
Thank you, Rachel. Our first myth is that older adults don't need routine HIV testing. New diagnoses in this age group are rare. That is a myth. Adults over 50 are accounting for a growing proportion of new HIV diagnoses, and they represent more than half of all Americans living with HIV. And so many times clinicians fail to offer older adults HIV and STI testing due to our assumptions about their level of sexual activity or their risk. This can be dangerous and lead to late diagnoses, which we'll talk about in just a second. The CDC guidelines recommend routine opt-out HIV testing through age 64 and for adults older than 64 with new risk factors at any age. And so we can't let our perceived assumptions or our assumptions about older adults get in the way of testing for HIV. Sometimes that can be a little bit of an uncomfortable conversation, but we have those CDC guidelines to fall back on. So it's opt-out HIV screening. Can be something very casual in that, okay, with your blood work today, we always offer HIV testing. You can, of course, opt out, but I find that by making it just a very casual sort of thing that's included in routine blood work, people almost never opt out. And to that point, let's take a look at stage 3. So AIDS, stage 3 AIDS at diagnosis by age in the year of 2024. So what immediately stands out on this graph is that the percentage of patients presenting with stage 3 AIDS at the time of their diagnosis rises steadily with age. So among the younger patients, 13 to 24, about 10% were diagnosed at stage 3. But around 45 to 54, that number jumps up. And then in adults over 65, more than a third were already at stage 3 when they were being diagnosed with HIV. And I think this really speaks to the fact that older adults are frequently not perceived by their providers or sometimes even by themselves as being at meaningful risk for HIV. And so HIV does not stop, as we can see, at 40, 50, or 65, but sometimes our screening habits do. And that is something that can directly harm our patients. And so really keep in mind, older adults need screening as well. And nearly a quarter of new diagnoses are in people who are 45 and older. So to that point, let's take a look at HIV prevalence by age as of 2023. So 53% of people living with HIV in the United States are 50 years and older. And the largest percentage, about a quarter of those, are people aged 50 to 59 years old. Next one. Even with effective ART, antiretroviral treatment, HIV significantly shortens a person's life expectancy. This is a myth. When HIV is diagnosed early and treatment is started promptly, people living with HIV can live just about as long as people without HIV and expect a normal life expectancy. So the primary drivers of mortality in these patients is late diagnosis, gaps in care, so falling off of treatment or falling out of care, and comorbidities, not necessarily HIV itself in patients who are treated. And if we take a look at deaths with HIV disease as the underlying cause of death between 1987 and 2023, we'll see that in the 80s and 90s, there was a very big percentage of deaths that were directly caused by HIV. But as access to therapies and therapies improved over the years, thankfully that number has gone down and down. So as of 2024, there were about 4,500 deaths with HIV as the underlying cause out of about 1.1 million people living with HIV. And so that is a significant improvement. However, I would say that 4,500 deaths in 2020, in these modern times with the access to treatment that we have is still far too many. So this graphic is very interesting. So this is really showing how dramatically life expectancy improves when HIV is diagnosed early and treated effectively. So here we're looking at people living with HIV who were on therapy with suppressed viral loads, and it's comparing their remaining life expectancy at age 40 based on CD4 count when treatment was started. So, really, what we see here is that as CD4 count increases, life expectancy for people with HIV gets closer and closer to that of the general population. So, for patients who started treatment with high CD4 counts, the life expectancy is really only slightly below the general population. However, those who started with very low CD4 counts had a pretty substantially reduced life expectancy estimate. And so, really, the take home message here is that the earlier we diagnose and treat these patients, the closer their lifespan will be to normal. So, this really is just driving home the importance of early diagnosis and sustained treatment. Next one. People living with HIV have the same comorbidities as people without HIV. This is a myth. So, although people living with HIV who are on treatment can expect similar life expectancies, HIV is associated with chronic immune activation and inflammation, which can accelerate the aging process. And so, we tend to see things like cardiovascular disease, bone density loss, kidney disease, and certain cancers earlier and sometimes at higher rates in people living with HIV. And so that's something for us as clinicians to be aware of and to be screening for. So, one thing to think about with patients living with HIV is that the statin recommendations may be a little different. So, people living with HIV have about a twofold increased risk of cardiovascular disease and develop cardiovascular disease up to a decade earlier than the general population. We're going to talk more on this in another one of our activities, but a fairly recent study, the Reprieve trial, recently gave us new HIV guidelines, which strongly recommend statin therapy for most adults living with HIV between the ages of 40 to 75 to prevent cardiovascular disease, regardless of their traditional risk scores. And so, again, this is something we're going to talk a little bit more in detail in our next episode, so be sure to stay tuned. We'll also be discussing other comorbidities, including HPV-related cancers, liver disease, and diminished bone density. So be sure to tune in to our next episode. Next one. Women with HIV should be advised against pregnancy because of the high risk of transmitting the virus to their baby. This one is false. With access to effective ART and appropriate management, the risk of mother to child transmission of HIV is less than 1%. And so women living with HIV can have healthy pregnancies, they can have vaginal deliveries, and their babies can be born without HIV. So, really, in our patients who can become pregnant or who are pregnant, our focus is really on optimizing medication and viral suppression, making sure that they remain adherent to medication and planning for that delivery, not discouraging motherhood. Next one, breastfeeding is not safe for birthing individuals living with HIV. This is a myth. So, for birthing individuals on therapy with a sustained undetectable viral load during and after their pregnancy, the risk of transmission through breastfeeding is less than 1%, but it's not zero. And so, in high resource settings like here in the US, it's traditionally been recommended to formula feed to reduce any sort of risk. But our current guidance is really supporting shared decision making for moms who wish to breastfeed. With close monitoring, of course, of both the mother and the infant. And so really here, the focus is more on an informed choice for the parents and adherence to antiretroviral therapy and close follow-up to keep the risk as close to zero as possible. So HIV is not an absolute contraindication to breastfeeding. Be sure to check out our website for links to resources on these topics.
Thanks, Asia, for debunking those myths and pointing out the truths about HIV. And thank you all for watching. Please check out episode 3, where we dive into myths about screening for HIV, diagnosis of HIV, and ART and primary care. If you'd like to claim credit, please click the Claim Credit button to take the evaluation. Your thoughts and comments are important and help us develop future education for MedMythbusters. For CME information, check out mythhiv.dkbmed.com. Did you know DKB Med provides no-cost continuing medical education for clinicians? Well, we do, and you could create a free account if you don't have an account already at dkbmed.com, and you could start earning your free CME and CE credits. See you next time.